will get better as they progress. So if the child has period abundance, but when they are in the adolescents or adults, the sequence will get much better, and they are not difficult. The other, which is most common, you will see is Klippel-Field syndrome. So again, Klippel-Field is this is your Klippel-Field, where there is a neck fusion. Yeah. So you will have a difficulty in having an ideal position for your intubation, because the neck is fixed, because these children have a cervical fusions. But again, this improves as the age progresses. And recently I've done a child with Klippel-Fields, there was a neck movement problem, but not difficult intubation anymore. So they improve. And then the other one you will see is Beckwith-Wildman syndrome. Again, you have a look at this. The tongue is so big. There's no space to put your laryngoscope. So these are the children who are difficult. So remember, sometimes some of the syndromes here, golden hearts, you cannot intubate. These children need tracheostomy, awake tracheostomy. So there are the children who, if they need surgery or they need optimization, you have to plan by tracheostomy in advance with the ENT surgeon. Okay. Now, as I was mentioning earlier, the difficult intubation in children is anticipated. So this is if it's an anticipated difficult, I'm going to spend a little bit of time on this one. If it's an anticipated difficult airway, you have to decide whether it's safe for induction of anesthesia. If it is not safe for induction of anesthesia, and induction of anesthesia is also for optimization, if the child has sepsis, and you have to decide whether it's safe. If it is not safe, you have to think about awake intubation or awake trachea with an ENT surgeon. If it is safe, and again, what you need to consider, whether it's safe or not, is whether the child has got full stomach, whether there is a severe airway obstruction, which if there is a severe airway obstruction, it's not safe for induction of anesthesia. And if the child is lying and is choking, again, it's not safe for an anesthesia. And it depends on the center where they're using. The tertiary centers where they do this on a regular basis, it may be okay for this group to have a safe induction of anesthesia as compared to the DGS, where we don't see them regularly. We have to think about either having an ENT surgeon early or transferring them, thinking about awake intubation or awake trachea. So if they're safe, if we think it's safe, and then still you have to provide passive oxygenation. And the passive oxygenation you can provide is by using the transnasal thrive, or you can use the nasal CPAP or high flow nasal oxygen. So passive oxygen, even if the child is not breathing, it increases your functional residual capacity by increasing the oxygen concentration in the dissolved blood. So passive oxygen works to supply that. And get an advanced airway equipment. So advanced airway equipment would be your glide scope, your AirTrack, your McGrath. Every hospital has got different types of advanced airway equipments for adults and children. So like we have here, we have got a McGrath for small, we have a glide scope, and we also have a CMAC. So find out what is there in your hospital for an advanced airway equipment for children. So once you have decided, and then if it's a difficult bag mask ventilation, then you have to, if it's not, and you think about, okay, I'm going to put the supraglottic airway device, which is again, is more relevant for anesthesia, not for an emergency medicine, because in an emergency, you have to tube the patient. So, but you can use the supraglottic airway device for a time being to help you ventilate if it's difficult bag mask ventilation, okay? Think about the other things. Again, this is very important in children. Shoulder roll, two-hand technique, ensure adequate depth of anesthesia, because this is one of the most common cause why ventilation is difficult, if the depth of anesthesia is not right. Treat laryngospasm. Again, early manipulation when the depth of anesthesia is not right and the child or baby goes into laryngospasm, Again, this is again one of the most common reasons why we have a difficulty in ventilation of children. And then relieve gastric distension. So put an NG tube early so that as we have seen, the diaphragmatic breathing is the most important. So, and if there is a stomach distension, the lungs are reduced, the lung volume is reduced, so it impairs your ventilation. So relieve your gastric distension. Now, if this helps, it's okay. If it doesn't help and you are declining saturation, then you have to think about whether you can wake the child. It's not possible if you are in anesthesia. It may be possible for an elective operation, but it's not possible when you're ventilating for an emergency if the child is sepsis or there are other conditions why the child needs ventilation and there's a declining saturation. Then you have come to the situation of whether can't intubate, can't ventilate, because now your saturation is falling. You are not able to maintain it by inserting a supraglottic airway device, and you can declare can't intubate, can't oxygenate, and you have to think about what are the options available for this can't intubate, can't ventilate. If it was unanticipated and it's an elective operation, you can think about reversing. If you're using rocuronium, you can think about reversing with Sugammadex. In the whole process, the thing to remember is minimum laryngoscopy attempts. If it's difficult, anticipated, always to be done by the experienced, whoever is the most experienced in intubation, and minimal attempts, because every attempt of intubation, you are increasing your chance of failure because it will cause your airway swelling. It will increase the blood. If you know, the video laryngoscopes don't work if there's a blood in the mouth. So again, you have to think about those things, that if you're using if you plan to use fiber optic or if you plan to use video laryngoscopes, you have to be very careful and with very gentle your laryngoscopy effects, and use airway adjuncts early. Use bougie early, use oral airway early rather than causing distensions. And that's the main thing here. So this is, I think I've just tried to explain what I was going to say. Now, once you have declared it's a can't intubate, can't ventilation, this should never happen. With an adequate planning, you can predict and you can plan. But you still have to be prepared for these situations of can't intubate, can't ventilate. And understanding what I've written here is understanding prediction of difficult pediatric airway and following DAS guidelines on unanticipated difficult airway should prevent can't intubation, can't ventilate scenarios. And if it's inappropriately managed, difficult airway in children can change a difficult airway to a disastrous airway. Right. So now we're going to talk about the can't intubate, can't ventilate scenarios in a child who is 1 to 8 year old. As mentioned in my previous slide, once you have identified it's a can't intubate, you can't ventilate, your oxygenation is going down, you try to optimize your position. You have given the paralysis, you should be adequately anesthetized, paralyzed. So you are treating your laryngospasm, your gastric distension. And then only you can think about, okay, this is actually can't intubate, can't ventilate, and it's a reversible causes have been ruled out. Attempt to wake up if maintaining saturation more than 80%. You can try that if you've used rocuronium, and which is the most common muscle relaxant in children. So the muscle relaxant, when we are doing a child emergency intubation in a child, we use ketamine, fentanyl, and rocuronium. So if you've used rocuronium and you can't ventilate and you've got the situation, then you can think about using Sugammadex for the full reversal. But if the saturation is less than 80% and failing, and you have said, okay, this is definitely can't intubate, can't ventilate, call for the ENT specialist, because in children, that is the most important thing, ENT. And if you look at if the ENT is available, your first options will be surgical tracheostomy or rigid bronchoscopy plus ventilate. And if you have done ENT list, you will see that the ENT surgeon can put the rigid bronchoscopy and then we can jet the patient. This may take some time if it's not set up. And then surgical tracheostomy. Again, ENT surgeon has to be comfortable in doing that, and they should be doing, but that is the best option. And thus, the success is possible in only this scenario. If you think the ENT is not available, and if you think there are other options, so other options we're going to talk about in a minute, which is the front of neck access, and I'm going to show you what are the options for front of neck access in children. So front of neck access is EFONA, your emergency front of neck access. There are different ways you can do it. You can do needle cricothyrotomy, you can do surgical tracheostomy, or you can do surgical cricothyrotomy. All of them have challenges due to collapsing trachea, which we mentioned earlier, because they have got a very flexible larynx and trachea, so that it collapses. And when you're doing these procedures front of neck, there's a chance that the posterior tracheal wall is ruptured or damaged. And they've got a narrow cricothyroid membrane, so there is a limited space to do the procedure. So needle cricothyrotomy, as I mentioned, it's very difficult in children, and we will see in a minute why it is difficult. Or let me show you why it's. So this is how you do the thyroid puncture, cricothyroid puncture. This is the angle where it should be. And if you see in a child or a baby, there is no space. This is your angle, ideal angle, and they have to be at an angle, but actually it's possible only to do as a perpendicular. And if you do perpendicular, the chance of posterior wall puncture is very high, right? So, and this is for both surgical cricothyrotomy or a needle cricothyrotomy. But if you're doing a tracheostomy, this is where you're going to go. It is slightly easier than your needle cricothyrotomy. The other thing which you have is surgical cricothyrotomy, which I'm going to show you again. It's a scalpel bougie tube technique, and if you see, that's the surgical tracheostomy, surgical cricothyrotomy. You use a scalpel, right? So you need a tube, scalpel, bougie, and something to clean. So clean, put the scalpel in, put the bougie in, and put the tube in. Again, it has got the similar problems with the needle cricothyrotomy. And in children, and in adults, I know surgical cricothyrotomy is better than needle cricothyrotomy, but in children, the evidence is that needle is slightly better, although it's not good, but it's slightly better than surgical cricothyrotomy. So the third thing which you can do is, which we talked about, and I think if it's possible, that's the best thing, rigid bronchoscopy with jet ventilation done by the ENT specialist. So this will buy time to do it in a proper way, surgical tracheostomy, if you do rigid bronchoscopy. Either way, if there is a intubation can't ventilation situation, the outcome is very poor in children. So we've talked about, this is your cricothyroid membrane. So if you're doing a needle cricothyrotomy, you need a cannula, you need a syringe, and it's basically then you use a rapid O2. So I'm not sure who has used rapid O2, but that is one of the easiest thing if you're successful with your needle cricothyrotomy. For the rapid O2, you need a cannula, which can be a gray or a orange cannula, and then you need a rapid O2 set, which is available in all the hospital. I mean, we've got available in our hospital. And it's used for needle cricothyrotomy, used with needle cricothyrotomy. It is easy. And because if you see what it is, you connect this tubing, you put the you put the cannula in, and you connect this tubing to the cannula. And this goes with the oxygen supply. And this is how you're going to jet. This is open. So you can open and close. This is for your jet. And it's very easy. And it's got the learning curve is very, very steep. Using the rapid O2, not the needle cricothyrotomy. The benefits are it's easy to use. The flow and pressure release during expiration is reduced because it's like an open place, and you can put your thumb in and take your thumb out. So the flow and pressure release is less. You inflate the lung up, and you put the finger in and see the chest rise. And once you've seen the chest rise, take the finger off. So it reduces the risk of hyperinflation and barotrauma. It raises the intrathoracic pressure. It reduces the risk of intrathoracic pressure, because if it's a barrel trauma, then your intrathoracic pressure goes up and your cardiac output is reduced, which we don't want. And there's a cannula which you can aspirate and see if you're in the right space. Now, this is a pathway we have in our hospital for pediatric rapid oxygenation pathway. So you set, once you've done your needle cricothyrotomy, you connect it with the rapid flow, rapid O2, and you set the flow rate according to the child's age. So say it's a 2-year-old child, you set 2 liters per minute flow. You jet for 2 seconds, see the chest rise. If you see the chest rise, then that's very good. Wait for 20 seconds and then do it again if needed. If you're not getting the good saturation with this, if your saturation is less than 95%, you increase the flow by 1 liters and do the same procedure again. You can increase the flow twice. And if by increasing the flow by 2 liters per minute, also there is no improvement, then, or obviously if there is a problem with your cardiac output, cardiac arrest or chest compression, then you go to you do the rapid O2, like every 15 compressions you do for 2 seconds, like you would do your pediatric cardiac arrest. If it doesn't work, then you have to think of the reason why it's not working. You can check if it's easy flow. If it's not easy flow, then you can aspirate. And if there is no air coming out, that means the cannula is misplaced. And that's what commonly the evidence is, that is the reason why we have got a failure rate of needle cricothyrotomy very high, because it fails, the cannula gets kinked, and it punctures the posterior wall. When you're using the rapid O2, you also have to put the supraglottic, you can use the supraglottic airway device to take the air out, to keep your airway patent. And remember not to overjet, because if you do that, your intrathoracic pressure will increase and your blood flow will decrease, your cardiac output will be reduced. So that's all from me. So I'm going to stop sharing and then we can go through the questions.
Fantastic, Dr. Retrieval. Thank you so much. I can see a couple of questions in the post, so I'll just go through those to begin with. If anyone has any additional questions, please feel free to add them to the chat. So the first question from Dr. Snelson in Norfolk and Norwich is, it's increasingly being said that needle cricothyrotomy is an ineffective procedure and it gives false hope, and perhaps it should be discarded for more substantial front of neck access. What are your thoughts on that?
Yeah, well, as I said, the failure rate is very high in needle cricothyrotomy or in any procedure. If the ENT surgeon is available, your best option is surgical tracheostomy or rigid bronchoscopy if you have an unanticipated. Clearly in pediatrics, as I mentioned earlier, the outcome is very poor if we come to that situation. We should never come to that situation of having a can't intubate, can't ventilation in adults, but forget about children. It's very difficult in children, and it is anticipated, so we can prepare. And again, what I mentioned is rule out the other causes. So rule out the laryngospasm, rule out the gastric distension where you can't ventilate. Because if you are able to manage the laryngospasm or your gastric distension, so it should really be very difficult intubation in syndromic children, which you can anticipate. And in those, you should plan for an awake trachea. And it is done awake trachea. So I have seen few, as I mentioned, few syndromes where you have a golden horse, and you will see that these children will have a trachea and it's maintained trachea throughout in the beginning of a few years.
Thank you. I can see that Edward's got his hand raised. Edward, do you want to unmute? And
yes, I just wanted to clarify the question really. So it's not so much to do with the clinical element of it; it's to do with the human factors. So if we know it's such a procedure that's so unlikely to be successful, And when you're in a high pressure situation, we're thinking about all the people here in this meeting, they're going to be in that situation, can't intubate, can't ventilate. You've got limited resources and a lot of stress. If you had to choose between just trying to work through every possible reversible cause or getting out a needle and doing a needle crike, I think that is the debate. What is the better option? Is it to do a procedure that we sort of makes us feel like we're moving forward, but very unlikely to, when there are other possible solutions, like you say, gastric decompression, remembering sort of just to work through all those other simple things that actually, if they were reversed, would be completely effective.
Yes, absolutely. I think it's the human factors is a big thing in all emergencies, particularly in pediatric emergencies. And the thing which has happened is the CATS checklist, which makes you think, okay, these are the things which are important. And I think, when I was preparing the slide, I always look out these things, but it doesn't happen automatically because intubation can't ventilate situation is not common. So it may be a good idea to have that in your checklist as well. It's not as a part of your CATS checklist, or to have these scenarios. Okay, if you can't ventilate, have you thought about gastric distension? Have you thought about laryngospasms? Having said that, it's not common for a pediatric emergency intubation because what is commonly used is rocuronium. And if you've used rocuronium for your intubation, you have an hour of your time when you, or at least 40 minutes, when you will not have an incomplete paralysis. So we used to use suxamethonium. Suxamethonium lasts for 2 minutes, right? So if you do a couple of intubation attempts and it fails, patient starts breathing up. Then you don't know, you can't intubate, you can't ventilate because the child is breathing up, or you can't ventilate because it's difficult. So because the suxamethonium has been replaced by rocuronium, the things are slightly easier, because if you have given rocuronium for your induction, you can rule out laryngospasm from the beginning, because if your muscle relaxant is working, that means you shouldn't have a laryngospasm. But you have to think about laryngospasm if you're using the suxamethonium, because the child will be waking up after 2 or 3 attempts of intubation. So I would suggest, if you follow a standard policy, and in a way it is standardized more and more with the CATS teachings, that you will do your fentanyl, ketamine, rocuronium, it's kind of standard. But people may have certain variations. So people who don't do this regularly may not be comfortable in using rocuronium. So I think it's more about education and human factors, rightly said, because if it is in your checklist, okay, if you have this situation, have you ruled out these things? Then yes, you can prevent this happening, and you can easily treat the reversible causes. In our hospital, we have got the rapid O2 kit in a difficult airway trolley. So everything is there. It's not, the equipment is there. The procedure, as we have seen, it's difficult because it depends on the child. You can't have a good position. There is no neck. You can't feel the space. And it's a lot is there at the time. There is a lot of stress going around. So even if the neck is there, you still can't feel it, because it's a very stressful situation when the child is desaturating and you are trying to put the front of neck access.
Great, thank you. I think that there's a question in the chat about managing laryngospasm, but I think you've probably covered that quite nicely with your suggestions about how to adequately anesthetize children, and potentially we could continue down that route in terms of deepening anesthesia if needed. But one of the other questions is about the age at which you kind of stop using surgical cryothyrotomy as first line and consider needle, with all of the caveats that have kind of come up at the moment about trying to avoid any of these situations if you possibly can.
Sorry, I didn't get the question. What was it?
What sort of an age would you, so in the Difficult Airway Society guidance, I think it says sort of under rates and over rates as the age categorization. And I think we were just hoping for some sort of clarification. At what sort of age do you start going for surgical cryothyrotomy as your first line?
So, I mean, as I said, 1 to 8, definitely you have to think about needle cricothyrotomy. And over 8, you can think about surgical. As you're more on an adult side, surgical cricothyrotomy is better because you have more space, and you can feel your cricoid membrane. You can use your scalpel. You can put a bougie in, and you can put the tube in, right? So as I mentioned, in small babies there is no space, even in so in those nothing works, to be honest. And lots of work in literature was done, and out of 12 out of 19 which were done in children have failed. So very little success, and the risk of kinking the cannula is very high. uh, I mean, the thing is, we can try it at the time, and I think it's worth trying if the child is desaturating in front of you and you have got no other option. So you should know, or we all should know, what is the needle cricothyrotomy, where is it kept, and if we are successful, how we should be able to give the oxygen. So we should all know that. But as I was mentioning, it doesn't work. I mean, I have never done it, and I've never come to the situation where you have to do the needle cricothyrotomy. But I've definitely seen difficult airways, and these are managed by planned management. So by awake fiber optics, we have managed by surgical tracheostomy in advance. So that is done, and that is the most commonly done in the most of the tertiary centers. So if you're anticipating difficult, and we have got a lot of adjuncts, we have got your air track, you've got your CMAC. So we have got more adjuncts than before, where we can use it for our difficult airway in children.
Thank you. And I think you spoke really nicely about how quickly these children are likely to desaturate for various different reasons. And I was wondering whether there are things that you do before you sort of anesthetize, or at the time of anesthetic, to try and increase your sort of safe apnea time. Do you use apnea oxygenation, for example? And if so,
Yeah, I mean, yeah, apneic oxygenation works. It depends on what are you anesthetizing. If you are anesthetizing on elective cases, it's very different. Elective cases, it's a very controlled environment. You've got everything in theaters. You can use your high flow nasal oxygen. We use Thrive. If I'm anticipating difficult intubation, I use Thrive from the beginning. So transnasal humidified oxygen in adults and children. So and that people have done the whole surgery just using Thrive. So so it is possible. So it's because the passive oxygenation works with a high flow nasal oxygen, and that will buy us time. And with the Thrive, actually, we will not see as many can't intubation, can't ventilation situations if we all use it, because we are still delivering passive oxygenation. In children, if I'm doing the in a pediatric ward, if the child is on a high oxygen, then we continue that high oxygen, nasal oxygen, as we are intubating, because that again your apneic time, once you are and you ventilate. So these the rapid sequence induction doesn't work in children. There is no rapid sequence in children. You always have to ventilate because they desaturate very quickly. Yeah, so I always ventilate. They always keep on having their high flow nasal oxygen as I'm intubating, and positioning is the most important. Yeah, there is a list which I can share a little bit later. What is the age and what laryngoscope per age, and what size tube? I mean, it's on the website as well, the CATS website. So you should have the adequate equipment. Shoulder roll, which I use most commonly, is always there when they're small babies, because that will maintain your neck in the best position of intubation. You should have two people, two experienced people intubating, because again, it's more like a human factors. It's a task oriented. One person can get task oriented and will lose track of how long has it passed and repeated intubation attempts. So you should always have two experienced people if you're anesthetizing a difficult airway in a child particularly, because then the other person can keep a track and take over.
Fantastic, thank you. I'm mindful of time, but I'm just going to try and squeeze in 2 more questions in 2 minutes if we can. So one, we know this is a really high risk situation but it's really difficult to prepare for this. What are your recommendations in terms of getting some training or practice? Have you got any tips for that? And the second is, if you don't have the rapid O2 available, then what's your alternative?
So I'll go with the second one first. So if you don't have a rapid O2 available, you can use the jet ventilation, ManiJet. And most people have used the ManiJet. If you have used them, if you see the ManiJet, and it's available in most hospitals, or almost every hospital should have a ManiJet. And it has got a marking of setting the pressure for infant, child, and adult. So you can set your pressure, inflate, connect the ManiJet to your, I haven't got the slide in front of me, but basically you connect your ManiJet to your needle cannula and then inflate for the chest rise for 1 second and then deflate for 4 seconds and then inflate. So basically that's how you can use it if you don't have a ManiJet. Rapid O2 is slightly easier because you don't need that much of training and equipment as compared to the ManiJet, where you need oxygen source to be connected with a pipeline, because ManiJet is connected with a pipeline as compared to the rapid O2, which you can connect with any oxygen. So it should be more easily available, rapid O2, as compared to ManiJet, because you can use in wards, you don't need a pipeline. But with in A&E or in theaters, we have a ManiJet as well. And regarding the training, I think simulation is one of the most important. We all know there's a lot of work going on in simulation, and practicing the more each case when you're doing, and we train our anesthetic trainees in that way, that you are doing a case, prepare, think about what all you are going to need, and prepare for all. So preparation is the key if you are managing these cases. But from the learning point of view, the more simulation courses you attend, or the more you practice with your team, because as someone mentioned, one of your colleagues, it's more human factors, how you work as a team, how you identify the situation and make yourself available. Okay, this is a problem, and how we can have all the help available.
Fantastic, thank you. I can see some more questions coming up in the chat, but I'm also mindful of time, Dr. Agarwal. Would you be happy to just put some responses in the chat to the 2 or 3 outstanding questions?
Yeah, that's fine. I'll put it there. Thank you very much.
Thank you.